Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice case of atypical teratoid rhabdoid tumor, but this time showing nodular growth pattern with its important differential diagnosis from nodular desmoplastic medulloblastoma. So this is a case of, This is a case of a 2.5-year-old female patient who presented with unsteady gait and squint and nystagmus, in addition to 6-nerve palsy, sluggish pupil of 6 months in duration, and she was found to have posterior fossa mass. And as you can see from the low power magnification, this is a small rounded blue cell tumor. This is an embryonal tumor, an important differential diagnosis because of the tendency to form these pale islands is actually desmoplastic nodular medulloblastoma or medulloblastoma with extensive nodularity. But please remember, always in patients younger than 3 years of age, you have always, regardless of the growth pattern, to consider atypical teratoid rhabdoid tumor. So remember, the cutoff actually for the age is 3 years of age. And this is the high power magnification of the tumor, showing the sheets of tumor cells with the tumor cells, some of which show this prominent nucleoli, and some myxoidish background, again, the prominent nucleoli. And here really comes into the differential diagnosis, the large cell anaplastic medulloblastoma, because of the prominent nucleoli, because typically the medulloblastomas in general don't show prominent nucleoli. The other tumor that frequently shows this prominent nucleoli is atypical teratoid rhabdoid tumor. So this is an important also consideration that should alert us to this possibility in the diagnosis. Now, usually, although when it was initially described, atypical teratoid rhabdoid tumor was solely for tumors showing the rhabdoid features. However, it has been evident with time that essentially many of those ATRTs don't show the typical rhabdoid cell morphology. If you look careful enough, you will encounter some of these probably scattered tumor cells with some rhabdoid features, but typically we don't see them in most of the tumors. And back again into the low power magnification, because I want to draw your attention to this area that I'm going to zoom in, which is the nodule and the surrounded tumor cells. And in the nodule here, as you can see, there is a neuropil, and then there is a lesser amount of tumor cells, a tendency towards the neuroblastic / neurocytic differentiation, or in a way maturation, while the tumor cells at the periphery in between the nodules is still showing the embryonal features. And higher power magnification, again with the neuropil in the background, with the cells really with larger nucleus, but in general there isn't any prominent nucleoli. And then this is exactly just to show you the interface between the nodule and its differentiation, the neuroblastic nodule, and the tumor itself, where there is a clear contrast in the morphology between both components. And again, this contrast would bring the desmoplastic nodular medulloblastoma into the differential diagnosis, but please keep in mind the age of the patient. And synaptophysin, again, beautifully highlights the nodularity, and on high power magnification, the nodule shows a strong synaptophysin positivity in the neuropil versus only the scattered synaptophysin positivity in the surrounding tumor cells. And this is high power magnification of the neuropil within the nodule, the better differentiated, the neuroblastic nodule. And because of the age, regardless of the growth pattern, INI1 SMART-B1 immunohistochemistry should always be performed. And this is the beautiful internal control, the nuclear staining versus the negative staining, both in the embryonal component as well as in the better differentiated or the neuroblastic component. And this is on high power magnification. The internal positive control is a must. We have always to ensure that our internal positive control is working properly before we interpret the negative nuclear staining in the tumor cell nuclei. This is outside the nodules, and this is on high power magnification. Within the nodule, again, the vessels serve as internal positive control, and the tumor cells, even the ones showing the better differentiation, are completely positive, are completely negative. Now, if you do not have INI1 at your lab, one way to render the diagnosis of ATRT is actually a combination of stains. Vimentin, which tends to stain the cells, especially with a globule or cytoplasmic inclusion in the tumor cells, and EMA, which tends to stain groups of tumor cells strongly and very brightly. So in combination, Vimentin and EMA can be very helpful to support the diagnosis of atypical teratoid rhabdoid tumor versus the diagnosis of medulloblastoma if you don't have the INI1 immunohistochemistry at your laboratory. So the final diagnosis in this case is actually atypical teratoid rhabdoid tumor, nodular growth pattern. Please remember that this pattern can occur in atypical teratoid rhabdoid tumor. It's not only specifically encountered in medulloblastoma, nodular desmoplastic medulloblastoma. In this tumor, in atypical teratoid rhabdoid tumor with nodular growth pattern, there is no increase in reticulin fibers in the background. The age should be an excellent clue for really suggesting this possible diagnosis in order to perform the proper immunohistochemistry. And this goes actually beyond just academic rendering. The proper diagnosis would mean intensification of the treatment, poor prognosis, counseling to the parents, and many others. I hope you find this tip useful in your daily practice. Thank you.